So for our last Kaltura interpretation lecture, we will be going over interpretation of trauma, pulpal, and periapical lesions. So what is trauma? So trauma here we're referring to just injury from external forces. So when we're talking dentally, we're talking things that can affect the crown, the root, or alveolar bone. So there's different types of trauma. The trauma we'll be going over is going to be fracture and displacement. So fracture just refers to the breaking apart of either the crown, the root, or the jaw. Displacement can be either luxation or avulsion. So luxation, we're talking about abnormal displacement of teeth. So this can be intrusion or into the bone, or extrusion or out of the bone, luxation. Or we can also be talking about avulsion. So avulsion just refers to the complete displacement of a tooth from the alveolar bone. So we have here the fractured crown of a central incisor. So this one's pretty obvious. So here's a fractured crown. It does most often affect the anterior teeth. So even though this is a very obvious fracture and this patient definitely came in and we were able to tell what was wrong, we still want to take a radiograph in order to evaluate the damage to the pulp and the root. So like we said, this is some very obvious trauma here that we see on tooth number 8. So even though this patient presents with this obvious trauma, our PA we're going to take to further assess the injury. So we want to check to see if this patient has any fractures along the root surface, if there's any widening of the periodontal ligament space, or any further periapical pathosis before we proceed with treatment. Next, we can also have a root fracture. So a root fracture is most commonly going to occur in the maxillary central incisor region. You can have a vertical, horizontal, single, or multiple root fracture. So root fractures can be difficult to diagnose. So if you get the x-ray beam perfectly parallel to the plane of the fracture, which you can imagine is really just going to be mostly luck, you will see it there appearing as a radiolucent line. However, if the x-ray beam is not parallel to the plane of the fracture, you may not be able to see it at all. So unfortunately, if you have this type of fracture, you might not be able to see it and make an easy diagnosis through radiographic interpretation alone, which is why we have things like percussion tests, or you can also do a referral for a CBCT or a cone beam computed technology 3-dimensional scan that can also detect fractures if further necessary. The other unfortunate thing about a root fracture is that you can't necessarily do a root canal treatment for fixing this tooth because the fracture runs through the pulp chamber. So a lot of times the treatment for this tooth can often be extraction. Next, you can have a jaw fracture. So most commonly, this is going to be observed on the mandible, and you're going to usually diagnose this through panoramic radiographing. On other radiographs, a fracture is very difficult to see, but when you can see a jaw fracture, you're going to see it as a radiolucent line through the bone. Maxillary fractures can be incredibly difficult to diagnose through a radiograph. So sometimes you can use things, again, like an advanced technology like a CBCT, a cone beam computed technology 3-dimensional scan, in order to get a more accurate diagnosis for a maxillary fracture. So next we're going to talk about resorption. So when we're talking about resorption, you can have different types of it. There's physiological or normal resorption, but you can also have abnormal or pathological resorption, referred to as either external or internal resorption. So when we're talking about physiological resorption, we're just talking about a natural process that we see with normal shedding of primary teeth. So this is just when your primary teeth exfoliate. This is what we typically see happen in the primary dentition with children's teeth. When we're talking about external resorption, however, we are not still talking about something that happens normally. This is pathological. So if we have external resorption, it's seen along the periphery of the root surface. Often this is associated with reimplanted teeth. So if someone has an avulsed tooth and we put the tooth back. Abnormal mechanical forces. So if somebody has orthodontic treatment that moves their teeth too quickly. This can also be from trauma, chronic inflammation, tumors and cysts, impacted teeth. It can be due to clenching or grinding, or even just idiopathic causes as well. So most often you're going to see this at the apex of a tooth. The root is going to appear, as you can see here, blunted, and the root also appears shorter than the rest of the teeth. So we can see here this tooth is a bit shorter. So why do we care about external resorption? Well, we can see here with the external resorption, if this tooth is getting shorter and shorter over time, it might lose stability and not be able to withstand normal habits of everyday chewing and functions. So it's something we need to monitor in case it needs treatment. Next, we have internal resorption. So internal resorption occurs within the crown or root of a tooth. It involves the pulp chamber, pulp canals, and surrounding dentin. It's believed to be precipitated by factors such as trauma, pulp capping, or pulp polyps, and it appears as a round oval radiolucency in the mid-crown or mid-root portion of the crown. So if this is seen, usually if caught early enough, you can use endodontic treatment in order to correct the deviation. However, if perforation has occurred or if this has gotten too big, the tooth does need to be extracted. So it's definitely something you want to diagnose early. And it's not something you can miss on a radiograph because here we see the internal resorption here. It's very obvious. So next we'll go over radiographic features of pulp lesions. So first we have pulp sclerosis. So pulp sclerosis is a diffuse calcification of the pulp chamber and pulp canals of the teeth. So it results in a pulp cavity reduced in size. So usually it occurs with age. So as you age, the pulp chamber will get smaller and smaller due to calcification. Also can be associated with things like clenching or grinding habits. And often there's little clinical significance unless it needs endodontic therapy. Next we have pulpal obliteration. So here is the production of secondary dentin that may completely obliterate the pulp chamber. So if we go back to pulpal sclerosis, notice how we can still see here very thin pulp chambers, very, very, very thin pulp chambers here. However, when we look here at tooth number 8, we see no pulp at all. So pulpal obliteration, like we said, secondary dentin that obliterates the pulp chamber. These teeth are non-vital, but they do not require any treatment. Next we have pulp stones. So pulp stones are calcifications found within the pulp chambers or pulp canals. They appear on radiographs as round, ovoid, or cylindrical radiopacities. They can vary in size, shape, and number, and in most cases they do not have any symptoms and do not require treatment. However, when I look at this radiograph, I notice something a little bit different. So when I look here, I'm looking at mostly tooth numbers 5 and tooth number 7. So 5 I'm definitely concerned about because look at all the resorption here. There's barely anything left of that root here. It's very shortened. So that is something I would definitely be concerned about. That tooth may be mobile. I'd like to see what was going on there. And then here on tooth number 7, where we have our pulp stone, we also have some external resorption. So what might be a concern here is that if we did need to do treatment, like if this tooth needed endodontic treatment, that pulp stone would definitely get in the way of this. So this is something we would definitely want to keep an eye on. So next we're looking at radiographic features of some periapical lesions. So some periapical radiolucencies we can have periapical granulomas or periapical cysts or periapical abscesses. So these are some of the radiolucent findings that you can have. So if we were to be talking about periapical granuloma, you're talking about a localized mass of chronic inflamed granulation tissue at the apex of a non-vital tooth. And if you're looking at a periapical cyst, this is actually the most common of all tooth-related cysts, typically asymptomatic, and it usually develops just over a long period of time, can be treated with endodontic therapy, or if necessary, meaning extraction with curettage of the apical region. But overall, if we're just looking at a periapical lesion, we're really just looking at this area here. So we're talking about the apex of the tooth there. So this is again the reason why we take a periapical image. So periapical PA, we're thinking pain. So this is usually what you're looking for. So the big one here that we're most commonly thinking about is a periapical abscess. So a periapical abscess is going to be a localized collection of pus in the periapical region of a tooth. So again, if the patient comes in, presents with pain, we take our PA, and this is usually commonly what we would see if they're experiencing that localized area of pain. So there is two different types of periapical abscesses. We can have acute or we can have chronic. So with an acute one, you're going to have painful, non-vital tooth. It's going to be sensitive to pressure, percussion, and heat. So percussion, that's when if you tap on the tooth, they would jump out of the chair. So the problem with acute is that it does not always appear in radiographs. So why is that? So with an acute infection, it may not have gone, the bone might not be as deteriorated as it would be with a chronic infection. Because remember what we talked about with Carey's interpretation. In order for something to appear radiographically, it has to be more advanced. So it's the same thing with Carey's. In order for periapical pathosis to appear in a radiograph, it needs to be pretty advanced before you see it. So acute may not be advanced enough for us to see. Chronic, however, will be advanced enough for you to see on a radiograph. But sometimes a chronic infection may be asymptomatic because the pus is drained through the bone or the periodontal ligament space. So sometimes you will have a patient who comes in and they have a huge periodontal abscess and they might have no idea that it's even there. You'd be surprised. So next, moving on to radiopaque periapical lesions. So this time we have condensing osseoitis. So condensing osseoitis is a well-defined radiopacity. It's seen below the apex of a tooth, usually with a history of a long-standing pulpitis. And this can vary in size and shape. It does not appear to be attached to the root of the tooth. And most commonly, this is the most commonly occurring periapical radiopacity, mostly observed in adults, and you're going to usually see this on a mandibular third molar. So let's look at the image we have here. So here we can see tooth number 30 is the tooth that has condensing osseoitis. So what caused this? So let's look at this restoration here. We certainly don't have very good margin on this restoration, and look how big this restoration is. So how big this carious lesion must have been when the patient came in. So what likely happened is the patient came in pain, and the doctor gave them a temporary filling with a medicated filling just to make them feel better and told them they needed to come back for a root canal treatment and a crown. But this patient, because not all patients are as invested in their oral health as we would like them to be, probably felt better after they left and never came back for that root canal. Thus what caused them to get that long-standing pulpitis, leading to the condensing osseoitis that we can see in this radiograph. The next one we have is sclerotic bone. So sclerotic bone is going to be a well-defined radiopacity seen below the apices of vital non-carious teeth. Its cause is unknown. It's not attached to the tooth. It varies in size and shape. It can be either smooth or irregular borders, and it's asymptomatic. Next here we have hypercementosis. So hypercementosis is the excess deposition of cementum on the root surface. So this can result from things like supereruption, inflammation, or trauma. Most often this is going to affect the apical area, which appears enlarged and bulbous. So when we look at the roots here, we just notice they appear more wide than they normally should. And affected teeth are vital and do not require any treatment. So next we'll just look at a few anomalies. So this is really a review from oral facial structures. So first we have concrescence. So here's what concrescence would look like radiographically. We remember dens and dentae, so a tooth within a tooth. So here, what tooth number do we have with dens and dentae? Hopefully you're thinking tooth number 10. So tooth number 10, we have a little invagination of another tooth here. Gemination, again, twinning of a tooth. And this is just a list of further review that you should do of different dental anomalies from oral facial structures that can also come up again in dental radiography. For some of you, I hope that you would be looking at this list and looking at your unknown radiograph and thinking, some of these look like they might be kind of familiar. Well, good luck studying and enjoy the rest of your day.